everyone from Cat Island in the Low Country. Before I get started, I'd like to thank Dr. Walker for the opportunity to participate in this educational series. I'd also like to thank the NCBH team for making it all happen. The title of this talk is The Cost of Peripheral Artery Disease Therapy and the Drivers of Those Costs. So disclosures, none relevant to this discussion. PAD patients are costly and they incur higher costs. One study compared PAD treatment costs with those of matched controls and found that PAD patients cost almost $21,000 to treat versus $12,500. Another study compared PAD treatment costs with all U.S. adults, and that study found that PAD costs were $11,600 versus around $4,200 for all U.S. adults. So who pays the PAD bill? Medicare and Medicaid pay 80%, in other words, our tax dollars. Now, there are many factors that drive up the PAD costs. Costs increase with disease severity. Non-PAD costs are high. Interventional therapy costs more than medical therapy or supervised exercise therapy. With interventional therapy, complications, mortality, and repeat interventions add to the costs. The location of care delivery is a factor. Frequent readmissions and inadequate medical management also add to the mix. We'll go through each of these in turn. Treatment costs increase with disease severity. Inpatient treatment for an IC patient is over $20,000. However, for a CLI patient, it's almost $32,000. Non-PAD costs are significant. Looking at cardiovascular hospitalizations, 43% of the costs are not PAD, they are the other cardiovascular diseases. But if you look at all-cause hospitalizations, 80 to 90% of the total costs are not PAD. Looking at costs of different PAD therapies, we have the interventional therapies, we have endovascular, inpatient costs around $26,000. Looking at bypass, the different kinds of bypass between $24,000 and $30,000. Pharmaceutical therapy costs $2,700 to $3,900, and supervised exercise therapy costs $5,400. Amputation costs more than revascularization. Initial procedure costs are very similar. However, we look at total costs, which is the initial procedure cost plus the cost of perioperative morbidity, mortality, and revision procedures, then the cost of amputation is over $40,000. And that compares with $27,000 for endovascular and bypass. With interventional therapy, mortality adds to those costs. The cost of an in-hospital death in general is $24,000, and in-hospital mortality rates vary with the interventional procedure. They're lowest with endovascular, 1 to 3%, and highest with below-the-knee amputation, 15 to 20%. Remember, these are in-hospital mortality. In-hospital revision rates at 30 days. These also vary. Amputation, above-the-knee amputation, 12% revisions. Below-the-knee amputations, 20% revisions. Bypass, 1 to 3%, and endovascular, 1 to 9% revision rate within 30 days. Looking at complications, they increase costs in a number of ways. First of all, the number of major complications associated with the procedure, the percentage frequency, and the dollar cost of each complication. Now, the most common complication with amputation and with bypass both is wound infection. With amputation, it occurs at a rate of 10 to 30%, with bypass at a rate of 4 to 23%. Endovascular, the most common complication is bleeding at a rate of 5 to 7%. The average cost of a complication, for example, wound infection, $21,000 to over $46,000. Bleeding can cost between $9,000 and $17,000. One study looked at the impact of complications in revascularized CLI patients, and they examined 2 complications. They found that surgical site infection, think wound infection, increased cost by 83%, and bleeding increased cost by 41%. Location of care delivery, also a significant financial impact. Reimbursements vary by location of care delivery. Inpatient hospital is highest, hospital outpatient, then ambulatory surgery, and lowest in OBL. So you have the same procedure in this example, tibioperoneal endovascular procedure, specific CPT code. The reimbursements for inpatient are $11,000 plus to $20,000 plus, and there's an additional physician's fee on top of that. Hospital outpatient, same procedure, $10,000 or so to $16,000, and OBL though, $5,000 to $14,000 plus, and the physician fee is included in those reimbursements. Repeat interventions increase cost. Think of repeat revascularizations as TLR. Repeat interventions cost more. If a bypass procedure is needed to revise an endovascular procedure as the second procedure, then the costs are 2.5 times higher than the initial procedure. Now, cost depends on the patient, the type of the procedure, lesion characteristics by task, and the medical devices employed in the initial and the repeat procedures. 2-year TLR rates vary by device, generally the highest with POBA, 40%, and generally the lowest with DCB, 14% or so. Now, one study found that a procedure with DCB cost less than POBA at 2 years. It actually cost $2,900 less, and that reflected fewer repeat revascularizations, even though there were higher initial device costs. Unplanned readmissions increased the cost. 30-day readmissions are 16% versus 18%. The cost of a readmission is 50 to almost 70% of the cost of the initial hospitalization. Readmission costs increase with disease severity, and one study found that national readmissions add approximately $400 million to total costs. Inadequate medical management increases costs. PAD is a risk factor equivalent for CAD. Yet, antiplatelets, antihypertensives, antilipids, and smoking cessation is underutilized. One study found that less than 40% were treated with all 4 guideline recommended therapies. The result, major adverse cardiac events, MACE, and leg events, male, higher mortality, and higher costs. So conclusions. PAD treatment is expensive. Patients cost more than matched controls. Factors driving up PAD treatment costs are modifiable or preventable. PAD costs increase with disease severity, suggesting earlier diagnosis and treatment could reduce costs. Interventional treatment is costly, and major amputation is the most costly. Complications, mortality, and revision procedures drive up interventional therapy costs. Cardiovascular events, undertreatment of risk factors, and unplanned readmissions increase costs. Optimal medical management is underutilized in PAD. This increases the risk of MACE, male, and drives up costs. High rates of repeat interventions increase the costs. CMS reimbursement disparities favor inpatient treatment, which increases total cost to society of the disease. And more research is needed on PAD costs and consequences. Thank you.